Welcome to this meeting of the Calderdale Health and Wellbeing Board. Which, again, holding virtually, but so live streaming for members of the public who want to follow it now or in the future. So can I just start off by confirming apologies and substitutes, Susan?
Yes, Chair, we have apologies from Chief Superintendent Richard Whitehead, Dr. David Birkenhead, Karen Jackson from Locala, but Rachel Foster is acting as sub, Julie Jenkins, but again we have Mark Randall acting as sub, Sue Lewis from Together Housing, Ian Baines, Councillor Ashley Evans and Councillor Megan Swift.
Thank you. Item 2, members' interest, and remind people to declare interest on any items they may have or declare them now if they prefer. Yeah, Adam, Councillor Wilkinson.
Thanks, Chair. Yeah, I'd like to declare an interest. I have a share in a community pharmacy in Calderdale, and I'll therefore leave the meeting when we get to item 9, just to avoid any conflict of interest or any sort of perceived conflict of interest.
That's great. Thank you. And any others of the usual ones? Okay, item 3, there are no items which we want to exclude press and public. Item 4 is the minutes of the meeting held back in February. Can I check if they're an accurate record or if there are any comments? Councillor Metcalfe, Bob, are you trying to come in?
Yes, thank you, Chair. I just had a couple of quickies on the minutes. So just a question on I think minute number 43, I think it is, top of page M49. That was regarding this communication teams creating a website for people's stories. Said it will be circulated. I'm assuming it's probably events has overtaken this. I haven't seen anything come out further. So I'm just querying whether that was ongoing or not. I just want to ask for a correction to be made on minute number 48 of the business. It does mention there the Calderdale Dementia Action Alliance. That's not correct. The minute should be about the Calderdale Dementia Friendly Community. It's a new organisation which the minute said was hoping to have its public event on the 22nd of April, which has obviously been cancelled, and there's a small team looking at when and how this can take place now. But it does need correcting, please, because I think there might have been an Action Alliance previously. So it's a Calderdale Dementia Friendly Community. Thank you.
Okay, I'm sure we can make that correction. On the communications one, Mike, can you advise on that?
I think that was a CCG issue, and Debbie Graham may be able to comment on that.
Okay.
Thank you, Mike. I believe that the team have secured the domain name. I don't think there's work being done on building the website, and that's probably why it's not being shared. But I will get an update and circulate that round.
Thanks, Debbie. Okay, if there's nothing else on the minutes with that correction that Bob...
Sorry, Tim, there was one from myself as well, if that's okay. Sorry, yeah, I was just getting to the right page. Apologies for coming in a bit late on that. So, page 3 of 71, Calderdale Cares, and then on page 3 of 71, yeah, the third bullet point mentions the high increase in number of GPs and staff. We're talking about the extra staff that will be coming into the PCNs over the course of the next few years. So we definitely won't be having more GPs. They don't exist, unfortunately, but definitely more staff. So I think we could say GP staff or practice staff would be more accurate reflection of the description from Dr. Ross and the PCN changes. And then on bullet point 6, says Dr. Ross advised that these problems were looked at by the hospital and some of the morning surgeries. And I don't understand the term morning surgeries there. Whether it's just different GP surgeries. So how the workload is flowing out, and some of the challenges between secondary and primary care was being discussed there in terms of workload. But I think it's just probably GP surgeries rather than morning surgeries, if that's okay.
Okay, so so I wasn't at that meeting, so I'm
No.
bent on others. But are people okay with those changes Stephen's suggested? Whether Sue's got a note of those, or whether we can perhaps just do. Yes, she has. So again, with that, people happy with those changes? Can I, with that, can I move us to accept those minutes as amended? Thank you. And take us on to item 5, question time. As I understand it, we don't have any, which is surprising, unless any came in late, Sue.
No, Chair, no questions came through. I checked this morning.
Okay, that's unusual. Okay, so item 6, which I suspect will be the one we spend most of our time on this morning, the summary and impact of COVID-19. What we've got in the agenda pack is 5 papers from different organisations, and then we've had the presentation from Tim from Southwest Mental Health Trust circulated separately, each giving an overview of where those organisations were at a particular point in time. So some of them are more recent than others. I think if we presented and went through each of the reports, we would probably not get far beyond the first one. So I think if it's okay with people, I'm going to take it that people have read the reports. And what I'd like to do is just sort of ask someone from each organisation just to perhaps briefly highlight for a couple of minutes, their main priorities or concerns, anything significant that's changed since those reports. Probably go, difficult to know which is the best way to change. I think I'll probably go around each organisation first and ask everybody to present for say things for a couple of minutes, and then open up to questions. Or again, I suspect we could easily get bogged down on, again, could spend a lot of time on simply questions to either the trust or the CCG, etc. So I wonder if I could start off, Anna, by asking you to make some comments from the trust point of view.
Yes, thank you very much. In terms of just presenting some information, if I just cover the changes that we've had to make in the hospital, some of the challenges that we have faced and are currently facing, our approach to learning from our experience, and where we think we are in terms of next steps. So in terms of the changes, I think colleagues will be familiar that we've, during the crisis, had to make significant changes, essentially to stop all non-urgent or elective work undertaken within the hospital, so any routine operations or outpatient appointments. And we also had to make provision to be able to segregate and cohort patients into COVID and non-COVID areas. That required significant redeployment of staffing across the trust, with staff working in areas they wouldn't normally work in and requiring retraining. To be able to offer some services to people that we weren't providing in the normal way, we provided a variety of digital options around consultation where we could. And the main focus was really about increasing our capacity to deal with COVID patients, and in particular the provision of critical care facilities. So we made provision and plans to increase our critical care bed capacity from 13 beds, which we normally have, up to 48, which was a significant undertaking requiring significant amounts of equipment we wouldn't normally have, and, as I said, redeployment and retraining of staff. We also worked significantly with partners and around the pathways out of hospital, particularly around end-of-life pathways, working with the hospice, particularly working with social care and Locala around discharge pathways. And that's been a really positive experience around the pace of some of the change that we've been able to make. A lot of the work was around colleague wellbeing, and particularly around the use of personal protective equipment and training, the supply of that, but also providing psychological and counselling support during that time, with paramount importance being placed upon colleague safety. The challenges familiar to us all are around the logistics around personal protective equipment, the logistics about testing and track and tracing, the logistics for us in terms of estate around we have had to and we will continue to have to provide zoned areas for COVID and non-COVID patients, and a physical separation of those spaces, and as we move forward, a separation of colleagues that work in those spaces so that they don't move between the two. That has significant impact on our capacity going forward, which we're currently working through and modelling. A particular challenge for us is that by stopping non-urgent work during that period, we now face significant backlogs, and as I'm sure everyone is concerned around patients that haven't received care, and about how do we safely restart services going forward. We are taking time to take a structured approach to learning from this experience. We've undertaken digital meetings across all of our clinical and non-clinical services during the end of May to actually find out colleagues' experience about what's worked well that they would wish to continue to do. And we've also had meetings with partner organisations, and we're drawing that together about how do we make sure we keep doing the things that have been beneficial and discard the things that haven't as soon as possible. Our next steps are cautious ones. We're cautious about how to restart services in the context of still potential for a second surge regarding COVID, and also around the normal winter surge in activity that we might see coming into hospital. I say that has to be matched alongside us having confidence around the supply and logistics around testing and around PPE supply. So I'll stop there and happy later to take any questions.
Thanks, Anna. If we go to the CCG next, is that Stephen? Are you leading off on this, or Neil?
I think I'm going to allow Neil to do that if that's possible.
Yeah, that's fine.
Is that okay, Neil?
Yeah.
Yeah, that's fine. Thanks, Stephen. Thank you, Chair. I take it most people have read the report, and a lot of the things are similar to Anna. There's been a lot of work, particularly working in partnership with social care and the hospital and primary care, particularly working in sort of step down beds and community beds and ensuring there are COVID positive and COVID negative. And I think since we sort of wrote the report, there's been a lot of work working with public health around support to care homes, around infection prevention control, and ensuring adequate training and support to those organisations there. I think going forward, it's exactly what Anna said around there are concerns about PPE. So whilst our general practice sites are sort of working on a hub model, there is questions being asked about whether individual practices are opening back up, and that will reflect a demand on PPE. And then also the guidance of if one person is ill, then whoever's come in contact with that, they've got to self-isolate for 14 days. So there's a resilience and general practice question going around, coupled to the availability of PPE, but then also the availability and strength of testing and tracing going into it. So there are concerns as the system sort of unlocks and breaks down as to how we sort of reset in a safe, controlled manner, considering the restrictions. The real pluses have been the working across partnerships between public health, social care, hospital, primary care, and mental health in getting everything mobilised. As a CCG, we've all gone remote, so we're not in the office. Staff welfare has been sort of paramount to us, so there's a lot of support in place in that to ensure that going forward. Happy to get questions, otherwise I'll be in fear of repeating what everyone else is probably going to say.
Thanks, Neil. If I go to the council next, you're seeing the report we have there, which is our kind of 10-point plan, which we're updating on regularly. I'm going to bring Robin in to sort of pick out 2 or 3 key points, and perhaps it might be worth bringing Debs in to talk about some of the test and trace things. We'll start with Robin. Where have you gone? There.
Thank you, Chair. I'm here. Yeah, so I think I think we all kind of understand that this has been the greatest challenge in public services in all our careers. The extent of that challenge clearly varies to some extent in terms of the roles that we have, but I kind of think there's been 3 phases to date on this pandemic. And the first phase was the crisis and the impending risk around the surge in our acute system and in our NHS. The phase that we went to and are still in to some extent, and then to some extent we're all in all these phases. The challenge around social care and the sector across not just care homes but all elements of social care, and then the phase that we're kind of certainly living in local government right now, which is the public order and the community impacts of all of this in all sorts of ways. So that those phases are something that we are very mindful of, and we've I've got a graphic to describe the challenge that we face next, and I think colleagues have eloquently described the challenge around resetting the NHS in the context of the demand that is there, and the ability to operate and respond to that, particularly in the acute setting, but also in primary care, I think, and rebuild better in a different way to provide health and care, so that some of the things that we've done that are positive can be built upon, particularly the use of digital and some of the work we've done in communities around prevention and how we build on that, how we build resilience in our social care sector. So we've all local authorities have submitted their resilience plans. They're currently being assessed. They're based around our care homes, but we've done it around the whole system of social care and its relationship to health, colleagues as well. And then the thing that I'll ask Deb just to come on to, which is the role around managing risks of outbreaks and building a real relationship of both testing, tracing and managing risk in both settings and in communities in the next few months. So we're in the heart of that. And also it's great that Ian, and I think maybe Ian Holmes on behalf of the Integrated Care System for West Yorkshire may comment on this from a West Yorkshire perspective, because we are very much part of a West Yorkshire system. Some of our health and care, quite rightly, is provided across the system, and some of the complex care that we provide is also at a West Yorkshire level for all the right reasons. So and we're very much mindful of the fact that there is a risk of not only COVID continuing to have an impact on health and well-being in our communities, and particularly those most at risk, and whether it's those with existing conditions, those who are particularly at risk in terms of things like diabetes, and it's National Diabetes Week this week. So just to kind of reflect on the fact that 26% of all deaths in the UK from COVID are people with diabetes. So the risk around diabetes, and then also the risks around our Black and Asian communities, and the work that the Public Health England's report has highlighted. And clearly there are people in our communities with a multiple level of risk. So we're very much in the heart of this. These issues haven't moved on. And then we had the secondary impacts of excess deaths around other frailties, other health conditions. And I think our conversation so far has been how we don't inadvertently have circumstances where people's health is impacted because of the challenges around COVID. So I think the message from all of this is that we have all sorts of reasons and right ones why we want to restart. We want to get things going, but this hasn't gone away. And I think maybe just the timing of this meeting is really helpful in, if it's possible, just maybe if our Director of Public Health can say something about the test and trace programme, if that's all right, because I think if we don't get that right, we can't recover, we can't restart, and everything that we've said so far won't be able to happen in the way it needs to happen, because we won't be able to manage risk effectively. And the need for everyone who is feeling symptomatic to get a test, and the progress is significant on that, and moving to a position where we will have test results within 24 hours is fundamental, because we can't contact trace and we cannot manage outbreaks unless our testing infrastructure can support that. So Chair, if that's all right, maybe if our Director of Public Health can say a few words so that all our partners and our communities in listening into this call can understand the importance of all of that, if that's okay.
Yeah, if that's okay. I'll bring Debs in next. Yeah.
Yeah, so one of our responsibilities, one of the important plans that we've got to develop by the end of June is a local outbreak management plan. What that does is it includes a number of elements, but ultimately it's to make sure that the test and trace programme works in Calderdale and for Calderdale residents. So as Robin said, test and trace and local outbreak management is really important, because as we start to ease restrictions, people will be in more contact with each other. And that then obviously there's always a risk, because that's how COVID transmits, by people being in touch with each other and in contact with each other physically and close contact. So the test and trace programme is about testing people, as many people as possible, as quickly as possible, getting the results quickly, and identifying the people that they've been in touch with and they've been in contact with. So close contact within 2 meters. And what we can then do is ask those people, those contacts, to isolate, as well as the person that's got symptoms that's tested positive. And that's really important, because that's the way that we separate people that have been in contact with the disease from everybody else. So that's really important. So our local outbreak plan will look at a number of elements. One is testing, so getting testing that works locally, so that's accessible to people in Calderdale, and testing where the turnaround, as Robin says, is really quick. Another element of the plan will be around communication, so that our communities understand how important this test and trace programme is. They understand how important it is to get tested, but also if they're contacted and told that they've been in contact with somebody who's tested positive, that they understand what needs to happen, that they need to isolate. Another element of it is making sure that those people get support. So we've already got fantastic community support hubs in Calderdale that are helping people impacted by COVID. And what will happen is, it may be that people that are asked to self-isolate maybe have problems with getting food, getting medicine, and even issues in relation to the income. So those community support hubs will need to support those people. And then really the sort of most critical part of this is us being able to look at patterns in Calderdale, patterns of cases, and start to think about whether we might have outbreaks. And we might have outbreaks in workplaces, or associated with schools, or in care homes or health settings. And what we'll do is by having that local information, we'll then get teams together to manage those outbreaks and contain those outbreaks. And that's really sort of how we respond when we start to see patterns of COVID in particular settings or in particular communities. And the final part of our plan that's important is having a really clear governance mechanism and governance arrangements, and so that local elected members can talk directly to the public and to the community about the impact or any of the decisions we need to make in Calderdale, potentially because of outbreaks. So whether that might be changing some of the restrictions that are in place because of specific local outbreaks. So where we are at the moment is we're working really hard on putting that plan together, on agreeing the governance arrangements and making sure we've got the capacity and the data and the testing that we need. And that plan will have to be submitted at the end of June. And we're working with people in all of the organisations represented on the Health and Wellbeing Board on that work.
Thank you. I appreciate the danger of this is people will have loads of questions that I have to keep remembering, but I've quite a lot of organisations to go through, I'm afraid. Can I bring in Tim next from Mental Health Trust?
Hi, thank you, Chair. Yeah, I just sort of focus on a few points from the slides that we'd already circulated, if I may. I guess the challenges, I won't try and repeat all the similar challenges that we're all experiencing, but perhaps those that are particularly important to us. First thing to say is that everybody here will know that and understand the impact on people's mental health that this virus could be causing. So the key focus for us has really been around maintaining contact with people during this difficult times. So what we wanted to do was make sure that we had all our staff had the right technology and support arrangements in place to allow them to do that. So it was all about making sure we had our VPN connections increased and Skype accounts increased and laptops, etc., enabled. And that was what we did very quickly over a very short period of time, which allowed us to then keep contact with a number of people that we do risk assessed across the whole of our system to ensure that we did maintain the contact at a difficult time for them and their families. Not only managing our sort of contacts through these remote routes, but we also improve the ways in which people get in contact, so streamlining the access through our contact routes, through our single point of access, and also making sure that we supported CCG colleagues the rollout of a 24-hour mental health support line, which I think was important in terms of ensuring that people had one place to go where they could be signposted to anything urgent. In terms of our support for patients on a day-to-day basis, clearly, as I say, the focus on maintaining contact and often through remote route, but we did and we continue to provide face-to-face contact in urgent circumstances with the necessary protections in place for people, which I think has been absolutely vital in terms of maintaining people's safety. I won't cover all the things that everybody else has mentioned in terms of testing and the work that's been undergone there, but I would say something about our inpatient service in the sense that the pressures that people will have experienced as a result of some of the visiting pressures and changes in the system. We had to set up sort of virtual visitor and virtual contact schemes through our iPad links, which I think has been helpful in a number of circumstances for people at a really, really challenging time. Similar to that Anna has mentioned earlier on from the CHFT, obviously, where we needed to, we set up cohort wards so people could be nursed in an appropriate environment, and that has been challenging for some people because obviously people aren't necessarily with the group of people that they would have anticipated, and that has caused some challenges in the system. In terms of our staff, excuse me, our staff position, clearly, you know, it's mental health. The mental health of the whole of our population is affected, so we need to consider our staff in the same group. We made some important changes there to our occupational health support through making sure that we have, again, another helpline for our staff and additional support to people who are shielding and making sure that managers have appropriate routes for contact and maintaining contact, because people can feel, as you know, significantly isolated. Other practical things that we've done is around making sure we have appropriate sort of food and drink available for people when they're finishing shifts or during the early stages when they were struggling to perhaps access some of the normal routes of shopping, even though there were some special arrangements made for us from NHS and social care staff, and I think that was appreciated by all. The other point I was just going to come on to towards the end was what we do next, and I think everybody's talked about sort of the challenges of reset. For us, I think everybody has the same set of challenges about what you bring back, what you want to stop that you've had to institute as a result of this current arrangement. But I think for us, it's also having a conversation about what we should expect in terms of demand. Because we don't feel that it's just the demand today, it's the longer term position, the longer term impact on people and their communities that we need to plan for as well. So we've been tracking some of the things that we feel might be important during this phase and see whether there's been any changes in comparison to situations last year in a similar time period the year before. So we're looking at that very closely. And the other thing I think is I think again, as others have mentioned, is making sure we get the best out of some of the things that we have done at speed, and understanding not only that it may be beneficial for those to continue, but also just being clear about the conditions that led to that change, so that we ensure that we institute that more rigorously across the organisation as part of our restoration reset strategy. So I think that's it. Thank you.
Okay, thanks, Tim. Just so you know where we are with people, I'm going to go to Topeka next, then Helen, Rachel and Ian to cover different things. So Topeka.
Thank you, Tim. Just want to say that the paper was some very preliminary highlights from a sector resilience survey, which we've been delivering out there. So basically, the voluntary community sector has maintained support and services as far as possible over the last 3 months. It's been focused on, you know, the sector's basically not only been focused on need, but has tried to be as agile and flexible as possible within resources. In our view, there's been 4 key areas that the sector has responded. One is around, or the community has responded, one is around the informal and neighbourhood groups. Second area is around community level support, particularly through the virtual volunteering hubs, which is a collaborative effort around Calderdale, and through the voluntary community sector itself delivering services. There's been a lot of cross sector and VCS peer-to-peer collaboration, and through that there's been a huge effort around making sure certainly families and the more vulnerable groups within our communities have had food. They've got access to good quality mental health support at a time when it's very difficult for many, and some really good evidence of cross-system solutions around voluntary sector working with our primary care networks and teams to deliver GP transport. So basically, and the further one is around the voluntary sector's role in terms of how we've been part of the system discussions, and particularly around planning moving forward. So all in all, we, you know, as a sector, the sector has responded, I think, very well under the current circumstances, and actually has been offering services, some essential services to communities at a grassroots level. The Sector Resilience Survey, the paper which has been shared, was carried out by the Voluntary Community Sector, the VSI Alliance, and what that's demonstrated very quickly for us is that demand for services and support over those 3 months had spiked quite heavily. Part of the reason for that is in the past, a lot of support would have been offered in group settings. A lot of the work has been done on a one-to-one basis. That has been impacted because of furlough, and there's also been quite a loss of volunteers within our sector. So there's going to be some work around how do we engage more young people within volunteering roles and supporting some of that. I think I'd also like to share that a lot of organisations' funding remains a challenge, and particularly for many organisations who are relying on donations and income through buildings will be particularly hit over coming months. And the greatest concern is over the next 6 months, we're looking at, on average, 50% of organisations starting to experience some financial issues and difficulties. And there's a report out recently that 1 in 10 charities will be going bankrupt over the next 6 to 9 months. So that's something that certainly we need to be looking at locally. Just a couple of other headlines. Obviously, the spikes in demand and support have been around those communities who have particularly complex circumstances. So you're talking about communities who are experiencing relapse in their health condition, or drug and alcohol conditions, or mental health conditions. You've got individuals experiencing domestic violence, poverty, particularly families struggling at this time. There's inequalities obviously within the BME and migrant communities and digital inequality has come out as key within this experience, and certainly this phase. So in terms of the future in response, I think the VCS are key to the future resilience of the place and people. It's really key that the voluntary community sector are integrated as far as possible, and as part of some of the systems discussions, that is what is being discussed. So Calderdale is well ahead in terms of how we're looking at planning and recovery. And certainly from a voluntary action Calderdale perspective, this has been there's been a real impact on workforce wellbeing across the sector. So we'll be looking at that to make sure the sector remains resilient, not only in terms of how we offer services and financial resilience, but the workforce are looked after too. We have also, just to finish off, submitted a couple of proposals collaboratively across Calderdale, and this has been truly cross-Calderdale collaboration for the Health Inequalities Fund and the King's Fund, which basically look at tackling inequality, making sure we start with what makes a good life, which I think is very key across Calderdale for our communities, and making sure that we focus on a community health approach and greater connections as we move forward. That's all, Chair. Thank you.
Thanks very much, Deepika. Helen, I know Healthwatch have been doing some work. I want to continue it on sort of patient voices, people's experiences during this. Do you want to say a little bit about that?
Thank you very much. So I know that everybody who attends Health and Wellbeing Board understands the importance of making sure that we're capturing people's experiences, voices, and their understanding of things across this period of time. But you remember that we had a development session earlier on this year where we looked at how we could work better in partnership to capture people's voices. And I know that the CCG had spent a lot of time with colleagues developing a new involving people strategy, which I know they hope to launch in April, but obviously events have taken over. But what we are trying to do, so I've worked with Jill at the CCG and other partners who are represented here and a wider selection of partners to develop a partnership approach in Calderdale to gathering feedback about health and care services during the COVID-19 pandemic. So we've developed a project that is centred around a survey which has now been distributed, and we've had almost 200 responses from Calderdale residents talking about their experience, and also some storytelling resources to kind of encourage people to share their experience in a different and more creative way. So we've created a range of resources for families and for adults, and all of that stuff's listed on our website for anybody to be able to access news. I can share all of that stuff. We've got a communications toolkit and all that kind of thing. So that's been shared really widely with partners. What we're hoping to do is capture a range of feedback, both things that have worked really well for people and that people want to see kind of sustained going on into the future, and also areas where things have maybe been missed or there have been problems with access, so that we can make sure that some of that stuff is resolved as we move forward as well. In terms of perhaps some key feedback, actually what I think we've heard quite a lot of so far is very positive stories about people's interaction with GP surgeries. I think we've heard quite a lot of stuff from people who have really valued the option to access a GP by telephone or by video call, and a lot of people saying, please don't make it go back to when I had to sit in a queue at 8 AM to try and get an appointment for that day, kind of make sure that some of this is sustained. But I think through speaking with a lot of community and voluntary sector organisations, we're very clear that access is only available for people who have that digital capability, and that there is a real risk that we will leave some people behind if some of that stuff becomes the default, and we just need to be really mindful of that, and mindful that that might not necessarily be the typical groups of people that we would expect to be less digitally capable. Healthwatch is producing a summary report of all of the intelligence that we've heard through our information and signposting service, and now through the survey as well, which we are sharing as regularly as we can. So I can certainly make that available to any partners. I know lots of people are receiving that already. In terms of a couple of just caveats that I wanted to sort of speak about in terms of the feedback that we're hearing, I'm really mindful that actually often we look at feedback in terms of the services that we deliver, but actually a lot of people have no idea what the ins and outs are in terms of what has been changed over this period of time. There's something about accepting what people tell us on face value and understanding that it might be transferable across a number of organisations, might the learning that we're given, and kind of being really open to that, to hearing any of that feedback. And the other thing that I've said in a couple of different forums that I've linked into is actions speak significantly louder than words, as we all know. And if we tell the public that something is important, but we don't actually prioritise it in terms of the way that we rebuild and restructure things, then actually they will get the message that it's not important regardless of what we say about it. So I think there's something really pertinent about making sure that if we are saying that early intervention and prevention is really significant and important, that is one of the first things that we kind of reset and rebuild, because it gives the message that it's important to us, not just important in, you know, sort of yeah. Well, but I think that's all that I'd like to say. Thank you.
Thanks, Helen. I think that point about what's important, I'm just struck by two things on that. One is, follows on from Deepika's point, and I've been in a number of conversations where people said how important the kind of community response, not just the formal voluntary sector, but small community groups has been. And then the next line tends to be, and I'm as guilty as anybody, but of course there's going to be no money going forward. And I guess the other area where I think, again, we need to think out very clearly is the inequalities agenda, and particularly the issue about Black and minority health has been touched on in a couple of the presentations about how, you know, the lessons this has raised about the vulnerability of particular communities. Again, it's time we don't just see reports telling us that that's an issue. It has to be reflected in the actions we take going forward. Sorry, I'm jumping in and commenting, but I didn't want to lose those points. If I can go to Rachel from Lacala and then Ian from West Yorkshire Partnership.
Thank you, Chair. Lacala's role in Calderdale is obviously around delivering children and young people services. That's the 0 to 19 pathway, public health, early years and school nursing. The biggest challenge for us has been obviously a lot of the venues where we normally see and connect with families, children, young people are not available to us, they're closed. We focused early on making sure that we'd got access to video conferencing, virtual contacts with families, children and young people, because for us the focus was on obviously families that were previously vulnerable and may have been receiving intensive support, particularly around potential safeguarding issues, but also recognising the circumstances we're in and the fact that we're all under restrictions that a lot of us have never experienced before, may have made some families who were previously not vulnerable more vulnerable under those current circumstances. So visuals are really important for us as well. So obviously where we can do things safely via a telephone, that's great, but there are circumstances that need to be picked up by seeing interactions between children and their parents and carers, and to see the home environment and things like that. So where we have done that, continue to do that on a face-to-face basis. Obviously, there's been a lot of screening and risk assessment around that, and being able to very quickly make sure that we've got access to video conferencing as enabled to do that remotely, but so not putting children and families at any additional risk of physical contact, but also keeping our colleagues safe as well. So video conferencing has been a great aid to us in making sure that we can continue to provide the contact and support that we need to for families, and we have volunteers as well, so enabling them to keep in touch in a virtual way as well around things like breastfeeding, peer support, and some of the other sort of peer-to-peer support that we've got in place that supplements and is very welcome to families needing that bit of extra support. We've had some national guidance. We had some early on that helped us decide how to prioritise our services. And as of last week, we've received some further guidance from NHS England, specifically around children and young people, that we're in the process of working through and implementing, which gives us some areas for consideration now about services that were seen to be lower priority and were paused, about how we now reinstate those as we come back to reset. So just to summarise, we've continued to provide children and young people services, albeit very differently in some cases, but recognising that families that were previously vulnerable still needed that intense support, but also how we identify families that have become vulnerable during the circumstances that we're in at the moment, and how we get them support where previously we didn't need it before. So I think that's all I wanted to say on that.
Thank you, Rachel. And if finally in this round I can go to Ian to say a little bit about the West Yorkshire Harrogate Health Partnerships work on recovery. If I can get it out, yeah.
Thank you, Chair. Morning, everyone. So my name is Ian Holmes. I'm Director for the West Yorkshire Harrogate Health and Care Partnership. So as you'll know by now, that the Health and Care Partnership is a partnership. It's not a statutory organisation. We don't have a formal role within the command and control structures as part of the response to the pandemic. But I think what we're really clear about, and what we've been clear about since the beginning of this, is that we'll only respond effectively if we respond as a system and if we respond in partnership. And I think some of the arrangements that we've put in place over the last 4 years through the Health and Care Partnership, will help support the response and stand us in good stead in relation to that. I think it's probably worth remembering that just before the lockdown, so on the 9th of March, we published our 5-year strategy. This is a document that we spent a lot of time with you guys and other groups developing. There's 10 big ambitions in there. It's stuff like narrowing the gap in healthy life expectancy, diagnosing cancers earlier so people have got a better chance of survival, how we improve the diversity of our leadership and how we support staff, and specifically staff from a Black, Asian, minority ethnic background, how we respond to the climate emergency that we're facing. And I think it's really important that when we're thinking about the response to COVID and the next phase of our response, that those 10 big ambitions are probably more important and more relevant now than they were even when we wrote them back in the early part of the year. So we must not lose sight of that. The way that we work across West Yorkshire and Harrogate is that it's very much a locally led, West Yorkshire supported model. We've got 3 tests for when we work together. So as a scale issue, do we need to work across places to organise services to get the best outcomes? Is there an opportunity to share good practice by taking what one place has done and sharing it with others? And one of the really powerful things that's come out of the last 3 months, I suppose, is some of the really great practice that we've seen locally and across West Yorkshire, and the opportunity to share that's going to be really important. And thirdly, are there any complex, wicked issues that actually a bit of support and a bit of coordination at West Yorkshire and Harrogate level might help on? As an example of that, we've established a West Yorkshire PPE group led by Mel Pickup, who's the Chief Executive of Bradford Teaching Hospitals, to support local places around that. So we've reshaped and refocused our work in line with those 3 tests, in line with the conversations that we've had across the system. We've probably got 6 overarching priorities moving into this next phase of the pandemic response. And this is how we continue to support people, how we improve outcomes for services, how we tackle some of the inequalities that we're starting to see play out, and how we continue to support staff in a period where coronavirus is with us. We're clear that for the next period, probably for the next year, we're going to be working in a situation where we've still got coronavirus, and it's how we organise services and support people in that context. So those 6 priorities are firstly supporting people with COVID, both in the acute settings, but also in recovery and rehabilitation. The second priority is around how we maintain essential services for people who don't have COVID-19 you'll have picked up that we've seen a big drop off in people presenting, particularly in the NHS, for non-COVID related issues. And some of the communications and some of the way that we support people to feel safe to come back is really important. So that's the second priority. The third area is supporting those groups who are shielding, and how we support other vulnerable groups, population groups that are likely to be disproportionately affected by COVID. Fourthly is how we support people who are working in health and care settings. This is how we directly support people now through providing access to personal protective equipment, so safe for them to work, but also thinking about some of the longer term impacts of COVID and psychological impacts of COVID on staff, and how we support them there. Fifthly, is the work that Robin Tuddenham's leading around with directors of public health colleagues across the system, looking at some of the direct and the indirect impacts of COVID. So we know, we're building an understanding of what the immediate direct impact is of COVID across different population groups. We know it affects older people more, we know it affects men more, we know it affects Black, Asian, minority ethnic groups more. There's still a lot that we don't understand about some of the longer term impacts, and also some of the longer term impacts of, social distancing, lockdown, etc. on population groups. So through Robin and Sarah and the work that we've kicked off with the university sector, we're trying to build a better understanding of that. And then finally, it's looking at the work that we do around stabilisation and reset, and how we bring services back in a safe way, and particularly some of those areas where we need a coordinated approach across West Yorkshire and Harrogate, potentially like cancer services, like the impact of that around critical care capacity, etc. So those are the sort of the 6 priority areas, and we've refocused all of our partnership sort of programme and working into those 6 categories. There's just a few things that I'd probably pick out as really important within that, just before I close. So firstly, our partnership board had a good conversation in March about our ambitions around Black, Asian, minority ethnic leadership. We've done an awful lot of work around that since then, and it's been really energised and refocused through the COVID incident. So we've got a network that operates across West Yorkshire, and we're using that group to work through how we get the right voice and influence of BAME staff into everything that we do, how we support recruitment and selection processes that are fairer, so that BAME staff have got an equal opportunity in those processes, how we support talent development and support the development and progression of BAME staff. And then finally, how we measure and how we understand the impact and difference that we're making. So that's really important. Secondly, we're doing an important piece of work across West Yorkshire and Harrogate around capturing some of the really great practice that we've seen. So Joe Farn in the team is leading on that, and we've got a website where we're asking people to identify and log good practice there, so we can share that with you afterwards. And then finally, at the partnership board last week, we had a conversation around the impact that COVID's had on social care, and that this was actually a really good moment to think again about social care and domiciliary care and the way that is delivered. And so I think we've agreed to a West Yorkshire and Harrogate wide piece of work, almost kind of reimagining the way that is delivered. And I think the sort of the COVID incident acts as a good prompt for that work to happen. So I'll pause there, Chair. Thank you very much.
Thanks very much, everybody. Thank you, Ian. So that's so we've taken up some time on that, as you'd expect, but I think that's given really quite a good overview of the different pressures and challenges of responses of different organisations. I liked, Ian, and I'd missed that, what you said about the website to capture good practice, and perhaps that's something we can kind of specifically flag up, because I suppose one of the things I'm interested in us drawing from this discussion and going forward is sharing, I suppose, firstly, anything we've done that's particularly innovative and important and worth and deserves recognition in people's responses to this. But then, of course, it's the learning and what needs to change going forward. If we allow about another 10 or 15 minutes of this, are there any questions or comments or views from people who've not spoken yet, or indeed people who have but want to reflect on different things that they've heard during that presentation? I'm trying to keep an eye for hands and comments at the moment. Okay, nothing immediate. I suppose if I could just add two things. Ian touched on the importance of West Yorkshire about the social care work and recognising that. I've also been involved as chair of the partnership board in 2 or 3 national discussions about among chairs about sort of learning from the response, and it does seem to me that in terms of you know, the big health trusts and everyone else in the system, that the way there's needed to be a cross-cutting response to the challenges of COVID really has brought home the recognition that the health service doesn't function in isolation, that it only works alongside local government, and that it's not simply about social care. Actually, it's the whole network of things. It's the community support. It's the range of things. And I think that opens up a really important opportunity in talking about local, regional and national structures going forwards, about how the different elements of public service work together, and we must not waste that opportunity. Stephen, did you want to come in on that?
Not necessarily on that, it was just a reflection on a previous comment. So I'm happy to come back later on if you want to take thoughts on that comment initially.
No, let's carry on, Stephen. That was just me.
No, thank you, Chair. Yeah, it was just a response, I guess, to what Helen very insightfully shared regarding friends who might be lost in the digital and online space, and also through just with not having no access to a telephone as well. And we do have patients who really struggle and have previously just walked into the surgery and said, look, this is my problem, I don't have a telephone, I don't have anything else, can you help me? But if we're in lockdown, they can't do that. I don't have any solution, but I would be certainly happy for the commissioning group to work with primary care and also with Health Watch and other partners to see how we can make sure that those disadvantaged individuals, communities who aren't necessarily the initial ones that come to mind, it's a whole array of different groups of people who struggle with various things, and we're pushing more and more online at the moment as well with e-consultations, etc. How we can work together just to see if we have any solutions to that particular issue.
Yeah, that's interesting. I can see Helen nodding on that. I was thinking about just nudging that question a little bit. You know, how far we've picked up with the shift to telephone and digital. You know, I think we all know there's people missing out, but just how far we really picked up what was going on. And I've got colleagues who've particularly been lobbying me about sort of the asylum seekers in supported accommodation, where apparently the providers don't provide broadband and access. Obviously that's a relatively small group, but I expect there's a wider one. I guess also it's a balance between it's both the physical access to it, but it's also the ability to operate it, isn't it? You know, we've all sat and laughed in meetings about people who can't get into the Zoom meetings, but actually if we're shifting towards more digital channels for health access, finding ways to make that as simple and robust as possible really, really is important. So it's not just about the technology. Do you want to come back on that, Helen?
Sorry, before Helen does, it's also the education sector is similarly challenged with young children who are struggling to get online and access education as well. Sorry.
No, that's fine. Helen.
And that's the point that I was going to make, is that actually one of the most significant impacts is young people who can't access schoolwork at the moment and who will face significant gaps in their study if they don't have that digital capability at this time.
Thanks. Debs?
Hi, yeah, I was just reflecting on what Helen and what Topeka said in their presentations about we talk about communities being important, but is that what we're actually acting on? And also Topeka mentioning the real concerns about the sustainability of the voluntary and community sector. And I guess I'm conscious that the voluntary and community centres at the heart of so much of what we were planning to do: social prescribing, community link workers, recovery and resilience. And I just wonder if there's some work we need to do quite urgently across the system, across local government, the NHS and the sector, to look at understanding the sustainability of the sector and understanding if there's any action that we can take together. I think if we left that 6 months, we'd probably be really sorry that, and look back and think, why didn't we do something when this was raised at the Health and Wellbeing Board? So just a suggestion as some action potentially.
Thank you. Yeah, I think Topeka, you want to come back on that.
I was just saying, yeah, thank you for that, Debs. I think it's really important that we think about or rethink how the voluntary community sector have a key role, and certainly across West Yorkshire and Harrogate Partnership and locally, really advocating for integration as far as possible, but also making sure that we look at ways in which to support the sustainability more dynamically of the sector, and how we can do that more collaboratively. So yeah, I think it's all about system discussion, system planning, and I'd really welcome that. Thank you.
Thank you. So I think we can perhaps partly pick that up through the health leaders discussion to think about a way that we take that forward. I suppose if there's an issue that perhaps I would have thought, that we've not really had time to spend on today, is perhaps a little bit more about the new normal and how health services start to change going forward. But probably also, I guess, linked to that, and perhaps this is one for a bit more of a development type discussion, is what the role of the Health and Wellbeing Board is in that, as part of that process as well. I suppose if people are watching this debate, what they've probably got out of it is a feeling of the scale of the change that different organisations have had to make to cope with this, but perhaps less about things going forward. And I suppose what concerns me about is we are slightly planning for the unknown going forward. That I think occasionally there is loose language used locally and nationally about returning to normal, and as a couple of people have touched on, we're not talking about going back to where we were before, certainly in terms of understanding what it's going to be like living with the risks of COVID infections and how that might shape out and what we need to do to prevent and manage that. Deb's talked about a bit in the outbreak plan. It creates a lot of challenges, and I don't think any of us really, certainly lay people, have fully adapted and acknowledged just what that's going to be like. But I guess also for professionals in the system as well, the challenge is there are a fair degree of unknowns. I don't know whether anybody wants to just sort of make any points about that one going forward. Tim, can I see you? Can I bring you in?
Yes, thanks, Tim. Yeah, I think your point about the role of the board going forward is really, really important. And I guess I think we've all probably been thinking about how we want to take our next steps and some of the challenges that we've heard here today. But I tend to feel one of the things that seems to be a common theme amongst all our discussions really is around sort of renegotiating what is provided to the people of Calderdale, or the public in general, as a result of this system. So it's how do we have that conversation on a local basis, for the people of Calderdale, about what things will look like in the future and how we'll be able to provide those services in a new way, rather than just making an assumption that what we've done in response in the short term is sufficient. I think we need to look at it in the round, and so it feels like we need sort of a structural mechanism, if you like, for ourselves as a board to have that conversation. And I guess that's probably the biggest challenge that we've got really at the time when we're sort of trying to fix the plane while it's in flight.
Thanks, Tim. I think that's really helpful. Stephen?
Yeah, just very briefly, another major driver has to be the environment as well. So there's been a massive positive impact, and we don't want to lose that in sort of reshaping the future, lose that important theme that's got to run through everything that we do. There's another emergency going on apart from the pandemic and racism in the world.
Thank you. I agree, Stephen. And can I just echo Helen's comments in the chat? I think they're worth saying about, what this has shown us about the resilience of our communities, the kindness of local people. These are things we really need to celebrate. The response has just been amazing in terms of neighbourhood support at all kinds of levels, and so much of that hasn't even required formal organisation. It's happening, and again, it's something that we need to find to motivate the response of staff in different organisations, as Councillor Wilkinson's reminded me again. Has been quite phenomenal, and let's keep recognising and celebrating that. I'm not sure, Mike, can I just check? I don't know whether we have dates. Have a date in the diary for next sort of formal and informal sessions. I'm sure we do, but I don't remember how quick they are.
To be honest, I'm not sure. I think we're working on that timetable still. I've just noted three sort of broad things for perhaps me and Debbie Graham and one or two others to look at taking forward. One is capturing the excellent and innovative practice and perhaps feeding into the website that Ian Holmes talked about. One is to work out a development session for the board on its own role in that, and also the new normal, if you like. So planning that as the next development session, if that's what you agree as a board. And the other is the points that Topeka and Debs have made in particular, and others, about the voluntary and community sector and the best route of picking up that piece of work as well.
Thanks, Mike. That seems quite a good summary. Are people getting a fair number of nods on that? Is there anything else anybody wants to say on this item? Robin, yeah.
Chair, just briefly, just to add to that list, the need for us to think collectively what our resource can be, on those that remain at high risk. So we haven't actually touched on the shielded people that are shielded in our conversation, and we have over 8,000 people in Calderdale now that are deemed to be vulnerable or extremely vulnerable, clinically vulnerable. We've got 113,000 now in West Yorkshire, and the role of the voluntary and community sector with us in supporting those individuals has been phenomenal. And whilst we anticipate that there may be national announcement about what that will mean going forward, because currently they are shielded until the end of June, we know that the issues that are the context for people in living lives where they have clinical risk isn't going to change, whatever the guidance might say. And that's a cohort that we are working at West Yorkshire level to support. And we had a discussion last night about that, because it's not just about food supplies, it's not just about medical equipment and supplies, it's about isolation, social isolation, vulnerability, and the wider factors that lead people to have poor health. So I think it's a commitment, hopefully I'm sure that the Health and Wellbeing Board would want to give, to continue to do all we can to support those communities, because it's likely that those individuals will be at greatest risk of poor health and also greatest risk of presenting to our services. So in terms of changing the way we offer health and care, I think that's a group we really want to focus on.
Thank you, agreed, and that's perhaps a strand we need to add to that. Look, thank you everybody for your contributions to that item. I do need to move us on to deal with a couple of other items on the agenda, but obviously that's been a really important and helpful debate, so thank you, and we will pick up and develop those strands going forward. Could I move us on then to item 7, which is approving the update of West Yorkshire and Harrogate Memorandum of Understanding, which danger of sounding very, very dry and technical after the discussion we just had, but actually the underlying principles about how we work together, which is what we're really signing up to, actually is incredibly important. And again, before I bring Ian in, I'll say it's been really interesting talking with the leads and chairs of other, if I dare use the jargon, integrated care systems across the country. That, I think it has been very clear that the partnership work that's been done in West Yorkshire really placed us in a very strong position in responding to this. But also it set in place a culture that said, we've got an arrangement and a set of rules and ways of operating here that we're simply going to apply and use, whereas it was clear in other parts there was much more of a culture of waiting to be told if they could do anything, because there's that kind of top-down mindset in some parts. So I think the work that's been done has really shown its value in here. But Ian, I'll let you do the formal bit.
Thank you, Chair. It's a really helpful introduction, actually. So we've got what we call a memorandum of understanding, and essentially this is a document that we first agreed in December 2018, and it describes the way that Harrogate Health and Care the partners within West Yorkshire Harrogate Health and Care Partnership will work together. So there's a part about the things that are important to us as a set of organisations and a set of partners, and there's a part of this that's about the how, which is the principles that underpin the way that we work and some of the governance structures that we've established to allow us to work in that way. So we went through a process to agree this in December 2018. It's really important to say that it's not a legal document. Partners kind of enter into this voluntarily because they think it's the right thing to do. It doesn't change any statutory accountabilities. It's a way of different statutory organisations working together. And we agreed that in December 2018, and at the time when we agreed it, we said we'd review it in a year. So we had an item at the partnership board in December 2019, which was a high-level review of the MOU. And the way that we did it was we said, we asked ourselves three questions really. Firstly, is there anything kind of operationally that's changed in the last year that means that we need to make changes here? Secondly, is there anything that we've learned by working differently together that we think actually we need to change to reflect that? And thirdly, is there anything coming out of the national policy around the long-term plan that requires us to change? And I think what we found in doing was actually the document was in a pretty good place, and actually a lot of what we'd included within that was then covered in the national long-term plan document, so we didn't need to make a huge amount of amendments to that. What we've done is we've tweaked a couple of areas. Firstly, we've updated our objectives to reflect the new 5-year strategy, which wasn't in place when we first agreed the MOU. Secondly, we tweaked a little bit of the governance to reflect that the finance forum that works across West Yorkshire and Harrogate has now been put on a slightly more footing, as is the relationship with the West Yorkshire Quality Surveillance Group. And the third thing that we did is we wanted to just make it more clear and explicit the way that we'll work with the public in developing our priorities and everything that we do. So it's three fairly minor tweaks just to reflect that. We have talked about doing more significant review when the time is right, if and when there's changes to the 2012 Health and Social Care Act. But at the minute, it feels like these arrangements are still maturing, still bedding in. So we've taken that light touch approach. The partnership board agreed this and was supportive of the changes when they discussed them in December. So I guess it's bringing it here to ensure that you are happy too. Thank you.
Thanks very much, Ian. Are there any questions or comments on this one? In that case, we're happy to agree the updated memorandum of understanding. Can I just confirm that? Okay. Thank you very much, everybody. There's a lot of lot of supporting papers and structures in there, but you know, the key points are the principles and priorities as Ian has set out. And I think the clarity also about why we do things at different levels, the 3 tests, again, is incredibly helpful and something. So I find when I talk to other areas, they're all quite interested in picking up on. So thank you for that one. Okay, that brings us on then to item 8, the early years peer review. I think it's Mark, are you going to start off on introducing this item?
Thank you, Chair. Thank you for consideration of the report in this morning's board meeting. I'm here on behalf of Julie Jenkins, who sends her apologies. And Julie did send, in preparation for the meeting, a report and then the wider report following the early years review. So just to give you some headlines and look through the report that Julie sent, in February of this year, we invited the Government Association to conduct a peer review, looking at all services within Calderdale, looking at all partners within Calderdale and reviewing our system. The focus of the early years, or the request, came from the fact that in Calderdale, our key indicator from an education perspective at the end of reception when children are 5 has been below the national average for the last 5 years, however, has been improving over the last 5 years and improving at a greater rate than national. So I think it's important to outline why we accepted and agreed to the review, which was very much led by us. And again, the review considered the work of midwives, health visitors, childminders, children's centres, libraries, everyone really who works with children, both not just in an education setting, but also in the vast majority of other settings. And the review identified many strengths, which was very positive for us in Calderdale. It identified through the review that there's a great commitment and ambition for children in early years. It identified that the partnership is well established, that there's good and very strong political officer support, officer leadership, that staff are motivated to change, and that within every individual area and then every individual service, that there, it is strong practice. The review did, however, highlight some areas for development, which is what we wanted to do, and it made mention that the offer was too universal and that there's not enough focus on our vulnerable children in Calderdale. I mentioned earlier on that our proportion of children who we would judge from an education perspective as school ready is below national. There remains significant inequality gaps between our children who are classed as not disadvantaged when we compare their educational attainment and outcomes to those who are disadvantaged. And the review found that the reason for that was very much because offers across services were too universal and not targeted well enough to support those families, parents, children who we would class as disadvantaged. The other findings from the report in terms of areas for development were really about a focus on outcomes and not outputs, that there remains a need to develop a cohesive strategy and a cohesive vision that's shared across all partners and all services working with children. And as a result of that, we would welcome a data sharing, information sharing protocol. And also we need to embed a children's voice and parental engagement within any work moving forward. So finally, the report did identify a number of recommendations. I won't necessarily read them out to you because I think they're very clear in the report that Julie shared already, and then the wider peer review report that was also shared. Just for your information, we have begun work in addressing the areas for recommendation identified. In some respects, COVID-19 has supported the work and the urgency of some of those areas being identified and addressed. For example, the information and data sharing protocol is much further on as a result of COVID-19 because we've had to work very closely with other partners to identify vulnerable children to ensure their safety and well-being, for example. But as I finish and then open up to any questions, then there is strong ambition. There are improving outcomes, but the need is very much now to develop an overall strategy that includes all partners, and a need to include CCG, speech and language, and midwives as well. The first 1,000 days of a child's life are extremely important, and what we do consider as being important and as part of that work is not just from the day of birth, but actually pre-birth as well. So the role midwives, the role speech, language and communication therapists, and the role other partners can continue to play in developing a cohesive strategy. That means we're all working to the same outcomes and on the same agenda to ensure that at the end of early years, the proportion of our children who are school ready, who do meet what we call the good level of development, will increase, and that inequality gap between our children who aren't disadvantaged compared to those who are disadvantaged narrows significantly.
Thanks very much, Mark. Adam, Councillor Wilkinson, did you want to add anything on this?
Yeah, thank you, Chair. Yeah, I won't go through all the sort of positives and negatives in the report, because I think you've obviously read it, and I think Mark's done a good job there of summarising. There were just really a couple of points I did want to stress, and the first is sort of the real importance of this work and the urgency that is mentioned by the LGA. I think, as Mark's kind of alluded to, I think there's a danger that this work gets lost a little bit now with everything that's going on with COVID-19, and we have to just really make sure that doesn't happen. I think, if anything, COVID-19 actually makes this even more important. Given that sort of vulnerable children are not going to have been going into school or nursery now for some time in a lot of cases, and won't be sort of seeing children of their own age and having contact with organisations and people in the normal way that they would be. There is a real danger that they'll just be falling back even further. So I think, for that reason, we need to have even more determination to get things right for them. And secondly, was just to stress the point, which again I think Mark touched on, and that is just how crucial it is that we have buy-in from all partners and organisations. I think it was really fantastic before the review happened. We had sort of a day together to prepare for it, where we had organisations from across Calderdale coming together to talk about, prepare us for the review, but talk about how we can do better for our youngest children. And it was really good to have that buy-in. But I think there has been some issues with certain health partners not being around the table in some of the initial meetings that have happened since the review happened. And I don't know if that might be down to issues with COVID-19, etc. But I just wanted to stress how important it is. And if we take anything away from this meeting, I'd like it to be that we really do need all health partners, public health, CYP, midwifery, speech and language, etc. Everybody around the table as this work progresses. So I think I'll just leave it at that, really.
Thanks, Adam. Neil, you wanted to come in.
Thanks, Chair. I mean, I like the report. It's fair and honest. I expect. It's just sort of one challenge for us, because it talks about being more sort of targeted, which I fully support. But when we do go into targeted, that sometimes results in small numbers, and there's always then a sort of a push for we need to do more. And actually, we need to accept that it will be small numbers to start off with, but that will create good outcomes, and it builds over time. And I think sometimes when you transition from sort of targets to outcomes, you can sometimes confuse it, and you don't always go on that journey, and you jump back to sort of targets. And we just need to be comfortable that sometimes this will be small numbers and targeted groups and not whole population. And so I'm supportive of it. I just think we can sometimes get confused in that sort of loop, really, sometimes, and just need to be wary as a board, that's all.
Thanks, Neil. Yeah, the universal versus targeted thing's not always without its controversies, it's fair to say. Helen, you made a useful comment in the chat about learning from family support centres, and support teams. Do you want to add anything to that? So, no, okay. And Rachel, thank you for your comment confirming Locala's support around this. Robin?
I just wanted to just echo Councillor Wilkinson's powerful words really about the need to not lose sight of this. We have a vision for 2024, and again, that's been something that's maybe been less vocalized in the last few weeks in the context of COVID. But in terms of resetting, the core focus around giving the best start in life and the 50 things to do before you're 5 that we launched late last year is fundamental to the health inequalities that we're trying to tackle. So it's not an either or, and I know that everyone understands that. And I think just going back to the shielding, we've done some work about the numbers of children, which we believe is over 1,500, who live in a household of someone that's shielded. And so in terms of the complexities of children's lives in Calderdale, and the fundamental challenge of around 30% of children not being school ready, it's not a great place to be, and we're at risk of that going in the wrong direction. So I think just to say that I think we all support that, and the needs of children's health is being attended to here, and also at a West Yorkshire level. So one of the core strands within the population health programme that Ian's referred to, that I'm jointly leading on, is about young people's health inequalities, and particularly young people's risk of getting involved in risk behaviours, and from early years into adolescence. So I think just to kind of offer some assurance that we haven't lost sight of this, and we will regroup and re-energise this work as we go forward.
Thank you, and thank you, Caroline, for your comment and commitment as well. So I think Councillor Wilkinson and I have got a discussion with Julie planned shortly about the governance going forward. So I think rather than focus on the governance of the covering report, I think it's important that we receive this report and if people are happy, specifically endorse the recommendations in the report itself, which are in section 2, the 9 key recommendations there. If everybody is happy with that, that's great. Thank you very much, everyone. Just bear with me because I've dropped my agenda.
Tim, could I just make a suggestion?
Sorry, yeah, sure.
Sorry, in light of the previous conversation that we had, I just wondered whether, if we are going to do a development session specifically focused around kind of COVID-19's impact and sort of how we can work together, should we structure that around the life course approach that we have for other things, so that rather than focusing on our kind of organisational boundaries, we look at what's most pertinent to the different sort of groups of people, because it might just help us to kind of think about it thematically rather than structurally, but that was just a suggestion.
Yeah, I think that's quite interesting actually. I see a couple of nods agreeing with that, and obviously there are some quite significant cross organisational issues. I think Adam touched on a few of the ones affecting children and young children particularly, but true of other areas as well in the shielding. So yes, so let's have a look at how we can do that and not deal with it organisationally. Thank you for that. That's good. Okay, so I think that brings us to item 9, the pharmaceutical needs assessment. So I know Councillor Wilkinson, I think you were dropping out for this item. Thank you. Although actually this isn't a massive issue when it comes to it. So Debs, you want to just explain the situation on this one for us?
Hi, yeah. Calderdale has a pharmaceutical needs assessment from 2018 to 2021, and you'll be aware that it's one of the statutory responsibilities of the Health and Wellbeing Board to make sure that there's an up-to-date pharmaceutical needs assessment. And as I say, ours is due to expire in April 2021. The government has contacted health and wellbeing boards and said that in light of the fact that the capacity that's dealing with COVID-19 is the same sort of people that would be doing the work on the pharmaceutical needs assessment, that we can actually delay the production of our pharmaceutical needs assessment for another year until April 2022. And so the recommendation, having looked at our pharmaceutical needs assessment, which identified that there weren't really any gaps in provision, and it made clear that made some specific recommendations around any changes in housing, etc. And I think we've got mechanisms to pick that up without having to go through the full pharmaceutical needs assessment process. The team that do this are the team that are doing all the surveillance around COVID across partners, so that are looking at the patterns that I mentioned earlier. And just from a capacity perspective, it would just be a real challenge to do that piece of work ready for April of 2021. So my recommendation, if you're in agreement, is that we take up the offer from the government to delay the pharmaceutical needs assessment until for a year, until the end of March 2022.
Okay, I'm getting nods of agreement about that. I suppose if I can slightly broaden it, I'm very happy with the idea of delaying the assessment. I mean, are there any issues on how COVID's affected pharmacies that we need to be aware of? Or is it simply that they're busier than they've ever been?
Yes.
Yeah.
I mean, I think, just say, Chair, I know through the LRF that the pharmacies were really struggling in the first few weeks around capacity and demand. I think that's settled a bit now. But in terms of the sheer demand and the powerful role that they do have, it's been a challenging time for them. I think Helen might want to come in as well, Chair. Sorry.
Yeah, Helen. Yeah.
I was just going to say, with being involved in the Health and Wellbeing Board in Kirklees as well, I've been involved in some of the discussions there about the PNA. I've set up a conversation with Ruth Buchan from Community Pharmacy to talk about the impact of COVID on access to pharmacy, because I feel like that's the most important thing to look at right now, rather than the pharmaceutical needs assessment. So any information that I get from that conversation, I'll feed back to Deb so that we're kind of linking everything together.
Thanks very much. So there's nothing else on that. So I think we're happy to agree to defer the assessment. Okay, thank you. So the final item is our work programme. Our next formal meeting is 13th of August. And I think the suggestion there, we've obviously put COVID-19 updates and impact on each item. I would suggest probably by the August meeting, we'll probably want to be focusing a bit more on the recovery, reset, renewal, whatever we're calling it, and how health services are starting to change in response to the new normal. But I think given the conversation about a development session, perhaps we'd want to look at whether there's a time to try and plan and do some of that work in a more informal setting in July to bring back to there as well. I don't know if there's anything else to pick up and add about work plan. No, don't think so.
Hi, Chair, can I just come in?
Yeah. Yeah, Neil. Yeah.
I think from a CCG perspective, in the sort of coming months, we'd want to bring some of the care closer to home work that we're doing with partners in. It links very much into Calderdale Clares, and we are sort of seeing some significant movement across all partners. So there's something about bringing an update and sort of next steps at the Health and Wellbeing Board probably needs to be cited on and sign off a bit, if that's okay. I'll have a chat with Mike about timings.
That's fine. Mike, you wanted to come in as well.
Yes, thank you, Chair. I've noted that one. We did say earlier in the meeting that we might be bringing the governance issue around the early years back to the next meeting. So that's perhaps something that we haven't got included on the 13th of October. And perhaps linking into the comment that Neil's just made, the Calderdale Cares locality perspective, if you remember, is where we pick up on one of the partnerships around one of the primary care networks. Now, whether we do pick one locality for the next meeting, or whether we pick up on perhaps perhaps Neil's item, I could perhaps discuss with Neil and Stephen to see how we pick that up outside the meeting.
Yeah, I think, well, I suppose the other aspect, which I mean, I don't think is an either or, but rather than an individual locality, it might be useful to bring something about how the localities have responded to COVID and how that's perhaps changed how we see those localities operating. Because I mean, I think they've been pretty crucial with the connection between the PCN areas and the community hubs in terms of community support. And I guess in a sense, that's probably given a reality to something that we were perhaps struggling to sell outside. So perhaps more of a reflection on that would be a good item. Again, I'm seeing some nods to that. So it seems to be some support around that. Okay, and I'm aware somewhere, Mike, I kind of batted back an item about sort of comms and engagement, which again might be picked up through the Calderdale Cares one, but was partly about me getting slightly mixed up between what we do as Calderdale Cares engagement and what we do as Health and Wellbeing Board engagement. But that was something else we wanted to just pick up outside the meeting and bring back to a future meeting without committing to which one, if that's okay.
Yeah, okay.
Yeah. Anything else, Stephen? Yeah.
Yeah, I'm not sure whether we've picked up in today's meeting or in the future one that's planned necessarily the severity of the impact on the emotional health and well-being of our population. So of course Tim had an update, but it was amongst many others, and I just have a feeling, and I think the evidence backs me up, that this is going to be the next sort of tidal wave of morbidity and challenge, not just within health service, but in the workplace, domestic violence issues, all kinds of different issues that it's ongoing, and then accessing care around this agenda as well, which has now moved obviously mainly telephone and online, etc., and just the challenge of that impact on the health and well-being of those delivering care for this population. So I don't know whether we need to have a greater focus, if we're looking at COVID and its impact in the next meeting, really about emotional health and well-being. I just think it's going to be a huge issue for Calderdale and for the rest of the country, but I'm just aware that that's something that really needs to be a clear focus, and we need to be mindful of it.
Okay.
Can I just add to that and just say that's really powerful, and I agree with Stephen. I think almost as a focus on our place in that conversation and a focus on our workforce. So you'll be aware, created a kind of Cedar Court provision for care to support potentially those that didn't have a care package, and Ian worked really hard with the team. But I know, talking to Ian and the brilliant work on that's primarily been a place where people experiencing significant mental health, placement breakdowns through the lockdown has become important. And I think there's an impact on the place, an impact on carers. And I think we haven't mentioned it's Carers Week, but it's an important week. We have 260,000 or so carers in West Yorkshire. I think just 4 out of 5 don't even tell their employer that they're a carer. And so we've been saying as a council, tell us. And then we have the harder edge of I think probably no other way to describe it, but post-traumatic stress disorder impacts for health and care staff working through the last few months. So it feels that it is something we should come back to as a specific item, Chair.
Okay, thank you. So probably do with a little bit of feedback between the meetings on when we're in a good position to update on the impact, that there is work going on that area. I don't know if, Caroline, do you want to say anything about that briefly? You just mentioned it in the chat.
I guess just to say that because the focus has been very much on physical health, I think up till now, although we've obviously kept that, particularly Tim's organisations, and I think every organisation has kept a very clear weather eye on the emotional and mental health impacts. But over the last sort of week or two, I think it's safe to say that we feel confident that we're able to kind of channel more energy into what we see as being the next biggest crisis, really, which is the emotional and mental health impact. And we are starting proactively to look at that as a system, not just with SWIFT, but with all partners across the system. So I think, you know, just to reassure you, there's a lot going on, and we can certainly keep you updated as a board.
Thank you, Karen. Helen, you've made a couple of comments in chat, but do you just want to come in on those? Quite helpful.
There was just an additional thing that I wanted to mention when we're talking about mental well-being, because actually we're providing some befriending support to people at the moment, and we know a number of other organisations that are. We work with a number of charities with groups that struggle to get out and about, and actually we're hearing quite a lot of stories from people who are currently better connected than they have ever been and are seeing a marked improvement in their mental well-being. And I think there's something that's really pertinent about us ensuring that we don't lose that momentum in terms of improving those people's well-being whilst we try to address some of the other challenges that are emerging around mental health. But it was just a reflection, that's all.
Thanks. Yeah, I mean, it is interesting that I've sort of suspected that, so it's good to have it confirmed. And I have noticed how many organisations, not just locally but nationally, have been doing work around how they can support people's mental health, you know, from kind of, you know, Woolshops putting out in Halifax putting out a package of information about mental well-being to, funnily enough, just whilst we were talking, I just got an email from my union about their well-being support service, you know. So there is a lot of that happening, but there's a lot of demand as well. Caroline, do you want to just come back?
Yeah, just to say that I absolutely echo what Helen's saying. There's a huge amount of positive stuff going on, but what we are very aware of is that a lot of this isn't sustainable and it's short term. And what we really want to do is over the next, well, as soon as possible, really, and certainly as quickly as we can, is to look at where people are getting that support from, try and address how much of it is sustainable and where it isn't sustainable, look at how we're going to fill those gaps as they develop. So just, I suppose, a quick plea out to everybody that anybody who has got, even if it's anecdotal, but anybody who's got stories and evidence of places where this sort of work has been going on and has been really successful, it would be really helpful to hear from those, because that will help us to put the picture together as quickly as we can.
Thanks very much. Hopefully people can pick that up and share it. Okay, I think that covers everything. So thank you very much, everybody, for your time and your contributions this morning. And we'll see you again when we meet formally, but I suspect we'll have some discussions before then. But thank you all for your contributions today. That was a good meeting.
Thank you.
Thank you, Tim.
Thank you, Chair.